probably 1.5 spotlight trials to make you aware of. I wanted to update the group that we had a very productive meeting on Zoom with our liaisons on June 25th. Among the things that people were very proud of is the spirit of trying to increase the catchment based on the challenge that we got from Dr. Wallmark about a year ago, different areas in the world that are not yet part of the energy vision. We understand that since there's a grant submission at the end of the year, that this is not the time to be pressing hard on that. But Mac Roach, who was unable to join us today because of some health issues in the family and apologize, has done a lot of work even looking at the issue of sites in Africa. He's been vetting, along with colleagues from the International Atomic Energy Association, different centers in different countries, such as Sudan, Kenya, and South Africa, who might have the potential to do SBRT work with credentialing and with good quality assurance. So again, it's not for now, but it's wonderful to see that spirit of volunteerism and generosity as we try and spread the word of quality work in clinical trialism. So as I said, there's a fair amount to cover, and I think we'll start with Mary Jo and the audit update.
It's been advanced for me. Great. Hello, everyone. Thank you so much for the opportunity to speak with you this morning. Just have some brief updates on the status of our international audits. Just wanted to mention that as an ongoing activity, our Saitama team, Dr. Fujiwara and his team are supporting local affiliate, the local affiliate audit process. So big thanks to the resources that they're contributing to the audit process. Thank you. For 2024, it's a fairly light schedule this year, just based on the rotation of audits. We have the clinical trials Ireland group with an audit coming up here in August, and that will be remote. And then looking ahead to 2025, there are 2 institutions that are slated. It will depend on accrual, whether or not those actually take place. And then since it's a light year for folks in terms of being audited, I thought it would be a good opportunity to remind everyone of some things just to keep focused on as you're working on our studies, some deficiencies that we've been seeing recently. So for the delegation of task logs, those are to be kept current with no gaps in approvals. If you have changes to the informed consent template, please reach out to NRG Regulatory prior to implementing any changes. If you have any study questions, always please reach out to the study team. That contact information is in the protocol document. And as you know, we're following the NCI CTMB audit guidelines for our audit program. And there's a link here in the slide. But additionally, I wanted to share with everyone that we're going to be posting NRG-specific audit manual, and that will be posted on the Energy Oncology website in the QA section. And that'll be coming in the forthcoming weeks. A notification will go out. So once you receive the notification and have an opportunity to review, if you have any feedback, please let us know. So we're excited about that. And thank you for the opportunity to share with the group.
Thanks so much. Are there any questions for Mary Jo? Okay. Then with that, we will move to Karen, who I know has a lot of interesting data to show us, and particularly this year as we anticipate the grant submission.
All right, thank you. Thank you, everybody, for the opportunity here. Good morning. So our current international membership as of the end of June were 73 active energy members, and they are across the various countries that are listed there. And North America. So Canada is not listed as an international member. I'll move. So these are the requirements for membership, and I've talked about these before. International members are at the affiliate level required to accrue at least 7 patients annually. This is the breakdown of the various types of members that we have in the international. The voting member requirements are listed here, 25 over an average of 3 years, or every year in the most recent calendar year, and to meet the data timeliness and quality reports. And of course, the affiliate members accrual does count towards that. International members obviously are eligible for that. So also wanted to point out that a portion of the foundation accruals, if any of the international members are participating in foundation trials, that does count towards the energy membership accrual requirements. Okay, so this slide I wanted to highlight. In putting together these slides, I noted that 37 of the 73 members have credited no cases to energy during the current grant period. And as part of our grant submission, each ex-US site must undergo State Department clearance and foreign clearance approval. And that is for new members when they're brought on, and then for each grant cycle, and that's for the NCTN and core grants. And so I wanted to highlight that the 37 members, they're in jeopardy, and it's possible that they may not be able to continue into the next grant period. And I say that because the last grant cycle, when we submitted, we were instructed not to submit any sites with 0 accrual during that period. And we anticipate that we will have the same direction from NCI when we submit for our grant. So wanted to also point out that it's important that the members receive the energy oncology news. We send various notifications out via newsletters, weekly broadcasts. The weekly broadcasts include a lot of important information regarding regulatory protocol updates, membership updates, opportunities for leadership and committee positions, publications, and other types of news. All of these are posted on the website afterwards and are available to access at any time. And if you're not receiving the weekly broadcasts, the person attribute for energy communications, that can be completed through the RUMS process by the lead research associate for the site, so that you get that. Or you can contact us at broadcasts at Energy Oncology, and we'll add you. So the other important piece that I want to highlight is to make sure to maintain the rosters. That helps us to make sure that you get the important information. There's certain roles that are required. At least one local PI and at least one local RA should be rostered per site. We're seeing that across the board. It's not just at the international members, but across the board we're seeing a little bit of gap in that. So review the rosters on a regular basis and make sure that the requirements for the roles are updated on your rosters. And again, the information is posted on the website. I've included the link there where you can look to see what's required. And if you want to contact us for membership questions or roster questions, I've included the email addresses and my email as well. Would love to hear from you. So thank you. Questions?
Okay. Thank you very much for that presentation. So now we'll look at spotlights. We have Energy GY036. And then, backed by popular demand, Dr. Gross will also talk to us a little bit about HN014.
Good morning, everyone. Can you hear me? Hi. Thank you so much for the honor of being here. I'm Ying Liu. I'm a GYN medical oncologist at Memorial Sloan Kettering Cancer Center, and I'm the PI for NRG GY036. It's a phase 3 trial of 1 versus 2 years of maintenance olaparib with or without bevacizumab in patients with BRCA1 or 2 mutated or homologous recombination deficient HRD positive ovarian cancer following response to first-line platinum-based chemotherapy. So we all are familiar in the room with SOLO-1 and PALO-1 and how they've really established the benefit of 2 years of olaparib maintenance with or without bevacizumab for those with newly diagnosed BRCA1 and 2 mutated or HRD positive epithelial ovarian cancer after response to frontline platinum-based chemotherapy. But the choice of 2 years of PARP inhibitor therapy here was empiric, and we're starting to see that extended durations of treatment with these PARP inhibitors may lead to increased toxicity, such as secondary MDS and AML, as well as potentially resistance to subsequent therapy. And the question here that we're trying to address is de-escalation of PARP inhibitor therapy possible in ovarian cancer? And so our specific question for the study is 1 year of olaparib maintenance with or without physician's choice bevacizumab non-inferior to 2 years of maintenance? And really, this came from data in pan-cancer meta-analyses of all of these PARP inhibitor studies showing that there is an increased risk of MDS and AML with PARP inhibitor treatment. And when looking at all these studies, the median treatment duration was 9.8 months, and a year may be sufficient. Additionally, in other tumors like breast cancer, the Olympia study have established the efficacy of adjuvant olaparib for 1 year in high-risk patients with BRCA-associated breast cancer, with improvements in both PFS and OS. And then finally, PALO-1 did not have an olaparib-only arm, and the true incremental benefit of maintenance bevacizumab added to olaparib is unknown. And so I just wanted to put the PFS curves here for both SOLO-1, which was just in the BRCA1 and 2 mutated subgroup, and PALO-1. This is the HRD positive subgroup that includes both the BRCA1 and 2 and the HRD positive tumors, just so that you guys could kind of see that. And this is the proposed study schema for GY036. We would propose to include patients with newly diagnosed stage 3 and 4 ovarian cancer. They would have a BRCA1 or 2 mutation, germline or somatic, or have an HRD positive tumor, and this would be defined using any commercially available test. These patients would undergo cytoreductive surgery, either primary or interval, and they would have a complete or partial response to platinum-based therapy. After the completion of platinum-based chemotherapy, they would be randomized within 3 to 12 weeks to either olaparib for 1 year or 2 with or without bevacizumab, and that's physician's choice, and the bevacizumab would end at 1 year. And then we are planning to stratify a priori on BRCA1 and 2 status, bevacizumab use, as well as response to platinum-based chemotherapy, PR or CR. And the primary endpoint here is investigator-assessed PFS versus RECIST. It's a non-inferiority study. But then secondary endpoints are going to be OS, PFS2, as well as safety, specifically looking at risk of MDS and AML. So the primary objective is to determine investigator-assessed progression-free survival using RECIST. It's a non-inferiority study for 1 versus 2 years of maintenance olaparib in the modified intention-to-treat population. And the reason this is as a modified population is that the time at risk for the primary PFS analysis is actually going to start 360 days after randomization. So patients will have to be on treatment for a year to enter this, and that's to account for the time when the 2 arms are getting the same treatment and any patients that may have progressed in that first year, which is a small population from the curves I showed you before. Our secondary objectives are going to be to evaluate overall survival, again, in this modified intention to treat population, but then we will also do a traditional PFS, PFS2, and OS in the intention to treat population from randomization as a sensitivity analysis. And then also look at PFS, PFS2, and OS in the as-treated population. And then we're also very interested in looking at toxicity, specifically rates of MDS, AML, and other secondary malignancies in the safety population. Our exploratory objective here is also to look at the moderating effect of physician choice bevacizumab on the randomized treatments, and to look at PFS, PFS2, and OS as supported by the intention to treat population. And so we anticipate, based on this design, we would need 880 patients and 382 events for a non-inferiority margin of hazard ratio 1.36. This is with a power of 0.9 and a one-sided alpha of 0.05. The patients we estimate to be in the modified intention to treat population, the ones who are getting treatment for at least 12 months, would then be 735. And this is based on sort of the loss that we saw in the SOLO-1 and PALO-1 trials. And then, of course, we would do the sensitivity analyses with the traditional PFS and OS as well. And essentially, we would be rejecting the null hypothesis if the hazard ratio is less than 1.15. So essentially, we'll be 90% certain that the true median PFS loss is not more than 10 months. We anticipate an accrual rate of about 15 patients per month after a 10-month ramp up, and so the total duration of the study is going to be about 88 months. And we do plan for 2 interim futility analyses at sort of 33% and 66% of the PFS events. So that was a lot of details. What makes this study unique? It's a pragmatic trial, so we're designing this to be streamlined. We're using commercially available drug to hopefully make this more accessible to sites in both the U.S. and internationally. We're one of the trials that have been designated to undergo streamlining process, so we're going to be trying to minimize our visits, the data collection as much as possible to make this as easy as we can for the sites. And this is a really important de-escalation question, and I think we're starting to ask more and more of these in oncology as a whole. We are allowing investigators' choice bevacizumab. We're not mandating its use, and I think this is going to give us flexibility in different countries and different markets because there's different approval rules around that. And we're going to be looking at both a PFS 360, taking into account that year where the 2 arms are getting the same treatment, as well as traditional markers of PFS and OS. We have partners in other groups like Alliance, ECOG, ACRN, and SWOG. And then today I'm here to hopefully convince you guys that international participation is also important. So thank you so much for your time. Happy to take any questions.
Well, thank you very much for your excellent and clear explanation about the new studies. So in my country, I've already started discussion about this protocol, and some investigator has the question. Okay, so I think that one very important question is that is there any preliminary data, retrospective data, which is showing the de-escalation of the 1 or 2 weeks to 1 year safe enough for the survival standpoint of view? And also, is there any data suggesting that the 1 year, the de-escalation of the period of the olaparib will give the patients of the decrease of the occurrence of the AML and the MDS variant population?
So it's a great question, and hard to answer, which is why we want to do this trial. I am personally not aware of any retrospective data looking at efficacy as far as 2 versus 1 year. I think because it is very hard to analyze real-world data about PARP inhibitor use in time. As someone who's tried to do this in our electronic system, it's unlike intravenous medicines. It sometimes is really hard to pinpoint exactly how long someone has taken a drug, and there's different levels to that. It's both the physician prescribing it and the patient themselves. So I think it's really hard to answer that retrospectively without a trial, without some kind of oversight in pill diaries. So I'm personally not aware of any data that would make us worry about the efficacy. I think in our real world practice, we all know that some people stop before 2 years for various reasons. As far as the other question, related to MDS and AML risk, there's again not any data specifically looking at, what is the marginal increase in risk from 1 versus 2 years. I think a lot of our data are emerging from the retrospective analyses of the PARP inhibitor studies in the second-line treatment setting, specifically SOLO2 and others. And in there, many of those patients were on much, much, much longer durations, even more than 5 years. And certainly we are seeing higher rates of MDS and AML in that group, but that seems like an extreme outlier. There may be some kind of continuous effect. I don't know necessarily the incremental effect between 1 versus 2 years, but I think looking at sort of other tumor types, 1 year we did extrapolate from that meta-analysis and also from the breast data. And again, I think the whole goal of this study is to help us understand that.
Yep. Thank you so much. And I agree that this is the long-awaited pragmatic trials in the G1 cancer field. So we're so excited to join your trials. Thank you.
Wonderful. Thank you.
Any other questions?
I was going to ask the same question. Data from MDS risk is a threshold. And so what's the percentage of patients now develop MDS when they're on a PARP inhibitor?
It's a good question. So it depends on the setting. I think a lot of it is influenced by the amount of prior treatment that may include platinum-based chemotherapy as well. So, the retrospective data from the recurrent setting with PARP inhibitor maintenance use, where the use was for much longer durations, for example, in that outlier group on SOLO2, where 20% or more of the population was on for over 5 years. Those rates are very, very high. I want to say in sort of the 10, 15%, even higher range. Again, those are all BRCA1 and 2 patients, and there's some thought that maybe the risk is higher in that group, although that is also controversial. I think in the frontline setting where this trial is, some of the newer data, some of it was presented, I think, from the MD Anderson group, and others have shown that the rate is lower in the upfront setting, and in treatment-naive patients, maybe more in the 1 to 2%, less than 5% range.
And then obviously this is late effect, so what's the time for them to develop MDS, and how long are you asking folks to follow patients on this trial?
Yeah, it's a good question. I think in the later setting, they may develop quicker in the lifespan of treatment-related MDS AML, but it's still on the order of, I think, 1, 2, 3 years, even 5 to 10. So that is, one of the questions. I mean, this study is going to be a long study. I think, we're already planning 7, 8 years. I think it is one of the toxicities that we're interested in reporting long term. So I think how to do that and both be pragmatic is one of the key questions. Absolutely.
I'll ask a question. I think it's a great study, and congratulations on getting it through all the steps and opening. First scientific question. Clearly, it's a pragmatic study. We're concerned about the risk of MDS. Are there any plans for translationally looking at blood for signs of CHIP?
Absolutely.
Or anything? That's the scientific question, and it sounds like a yes to that, so great. And the logistical question, as it stands now, is the only way for international members to join the study is through energy. It's not through GCIG or other international consortia, or is it, or will it be? Or?
So to answer your first question about translational objectives, absolutely. It's been a balance to try to make it minimal, a burden on the sites, but still build in translational science. Liz Swisher is the translational lead on this study, and there's a lot of interest, and she's done a lot of work looking at clonal hematopoiesis, so there is definitely interest in collecting, baseline tumors and then blood at 1-2 years, and then also in follow-up. So that's definitely part of the study that we hope to do. To answer your second question, right now we're in the process of trying to open it through NRG. I'm not sure sort of about the future and other international organizations, but definitely, we want to do what we can to make this as broadly available to people and accrue these patients.
Which some of you may not be aware is a group of international groups interested in gynecologic cancers and has done mainly working with sort of not industry supported, but sort of non-industry supported trials. So I think that's something to certainly explore. In fact, might look to talk to Dr. Bookman today.
Sure, that would be great. Wonderful. Thank you all.
Okay. Oops. Congratulations again. So we now have, I guess, back by popular demand, Dr. Neil Gross. There was a lot of buzz built around HN014 at the last meeting. There's tremendous excitement, and wanted to hear a few words from him again.
Well, great. Yeah, thank you for inviting me back. Can you hear me okay?
Yes.
Okay, great. I'm just asking because I'm driving. I'm on my way actually to the airport to come to Denver. But wanted to take the opportunity to kind of give an update on HN14. This is for resectable cutaneous squamous cell carcinoma, which I think, as many people know, is really a global health problem. And so we're really excited to have this be an international collaboration, particularly between NRG and TROG. The study is planned to open in the US, Canada, Australia, and hopefully Japan. So that's kind of the overview of how it kind of fits into the international committee. Just briefly wanted to touch on the background phase 2 data. This was the non-randomized trial in the US, Germany, and Australia for patients with resectable cutaneous squamous cell carcinoma. There were 79 patients that were treated. And of those, about half had a complete pathologic response. So there was an early readout and generated a lot of excitement for this. Next slide. The impetus for this trial is that not only did we see pathologic responses, but those were associated with durable disease-free survival. So this Kaplan-Meier curve shows the estimated EFS for patients treated on the trial. This was published last year and presented last year. We have updated data to be presented in September at ESMO as well. And I can tell you that it looks pretty similar. Bottom line is that patients who have any degree of pathologic response fare well compared to patients who do not have a response, you can see in red. So complete pathologic response, near complete, or what we call major pathologic response, or even up to 50% decrease in tumor. All these patients do better than patients who do not respond. Next slide. The caveat is that in this trial, adjuvant treatment was at investigator discretion. At the time, we didn't know what was best for these patients. There was discrepancy among investigators about how to manage patients depending on their pathologic response. So it was open-ended. Patients could receive observation, they could receive adjuvant radiation or cemiplimab. And what this slide shows is that patients who had a complete pathologic response, most of those patients were observed, and we know that their survival is excellent. So we know patients who have a complete pathologic response probably don't need any more treatment. And then patients who have less than a complete response in the phase 2 trial, most of those patients receive some form of adjuvant therapy, either adjuvant radiation or adjuvant cemiplimab. And by doing so, they also had an excellent outcome. So we've incorporated those principles into the phase 3 trial. Next slide. So this is the updated schema. This trial has gone through the NCI CTEP and has recent approval for that. We had a pre-IND meeting with the FDA and we've had feedback. And so this is the latest schema. Currently, it is at the CIRB, and we have follow-up with the FDA as well. But our goal is to activate this in the fall, likely in October. So it's moving along, and this is the current concept. So you can see that patients are randomized 1-to-1. It's for patients with stage 3 or stage 4 resectable cutaneous squamous cell carcinoma, and it's not just the head and neck, it's head, neck, and non-head neck sites. We are including selected immunosuppressed patients, so HIV positive patients who are well controlled on antiviral therapy, and CLL patients who are not requiring treatment are included. And this is unique for this population. All of the studies to date have excluded any type of immunosuppression. But you can see from the schema that the standard of care at the lower arm is surgery followed by adjuvant radiation. And the indications for radiation in this trial are standardized largely along NCCN guidelines. And then in the experimental arm, patients will receive neoadjuvant cemiplimab up to 4 cycles. So they'll get 2 cycles. If they're responding and do not have unacceptable toxicity, then they'll go on to receive up to 4 cycles, and then they'll have surgery. And the surgery can be adapted based on the tumor response. So if the tumor shrinks, the resection can be smaller. If the tumor grows, of course, the resection would be larger. And then we use the pathologic response as a biomarker to direct adjuvant treatment. So as you can see here, patients who have a complete pathologic response, a PCR, they go on to observation, no further treatment. So just neoadjuvant therapy, surgery, that's it. And we know from the phase 2 data that we have confidence that these patients will do well, provided that we have adequate surgical resection and pathologic sampling, which is a big part of this trial, is the quality assurance around those 2 elements. And then patients who have a non-path CR will go on to further treatment. They will receive adjuvant radiation if they meet an indication for radiation, and the indications are the same across both arms of the study. And I'll review those a little bit shortly. So patients may or not receive radiation, but all of the patients in the experimental arm who are non-PCR, after radiation, if they receive it, will receive up to 4 doses of adjuvant cemiplimab. So the primary endpoint is event-free survival. And we have a number of important secondary and exploratory endpoints, including patient-reported outcomes and quality of life. And you can see there that the sample size is 420. Next slide. Okay, so the primary objective is to demonstrate improvement in event-free survival with the neoadjuvant approach. Next slide. These are the secondary objectives. Importantly, we want to look at pathologic response in the experimental arm, similar to what we did in the phase 2 trial. Next slide. These are the patient-reported outcome measures that we hope to include. You know, there is really a dearth of data in this patient population. There's, in fact, only been one randomized phase 3 trial published for this disease ever, and it was a negative trial. So not surprisingly, there's really no validated quality of life instrument for this patient population. ERTC QLQ-C30 has been used in small studies, and so we are including that here, but we're also developing a sort of fit-for-purpose instrument that can be applied in the future for cutaneous squamous cell carcinoma patients. So during this trial, we are developing an instrument that we hope will be useful for future studies. Next slide. And then these are some of the exploratory objectives. You can see highlighted that we will be looking at PD-L1 status and see how that correlates with pathologic response and EFS. Importantly, we'll be looking at differences in the surgery between arms, how many lymph nodes are removed, the size and dimensions and volume of the tumor specimens, as well as the application of adjuvant radiation. Next slide. So these are the inclusion criteria. Again, resectable advanced stage cutaneous squamous cell carcinoma. And so AJCC 8, stage 3 or 4, or UICC if it's non-head neck. Now, it can be primary or recurrent disease. We are excluding patients with any mucosal primary, and that includes the vermilion lip. And as I mentioned before, selected immunosuppressed patients are going to be included. Prior radiation is allowed, but you can see with the asterisk there that it has to be to the extent that would allow adjuvant radiation if needed. And so there are very specific guidelines around that written in the protocol by Chris Barker, our radiation oncologist. Next slide. So the neoadjuvant treatment, as I mentioned before, is up to 4 doses every 3 weeks. And there is a response assessment after 2 doses, and this matches what was done in the phase 2. Next slide. Importantly, the surgery can be adapted to response. And I have examples of this, and there's a lot of surgical training and surgical quality assurance that will be embedded to make sure that this is uniform across the trial. But the goal is to complete an oncologic resection of any residual viable tumor, either seen clinically or on imaging, with margin control of the primary and resection of any nodes that are residual after neoadjuvant treatment, and in particular, including any nodes that were involved prior to treatment. Next slide. So here's an example. This is a patient that was included in the pilot trial that we started in 2017. This was at MD Anderson only. And this was actually one of the early patients that we treated with this neglected tumor on his cheek. And at baseline, he was recommended to have radical excision of his cheek, total auriculectomy, lateral temporal bone resection, prostatectomy, neck dissection, and free flap reconstruction. And the way the trial was written then required that after neoadjuvant treatment. And so even though he responded, as you can see on the right, he still got the same surgery. So he had a total auriculectomy, lateral temporal bone resection, parotid neck dissection, free flap. On this trial, we would allow for oncologic resection of the reduced specimen or residual tumor here, but in this case, it would spare his ear. And we think that's important, of course, for quality of life. Next slide. These are the indications for adjuvant radiation. And again, these apply to both arms of the trial. It's easy in the standard of care arm. These are pretty standard indications, at least in the US and Australia. Patients who have any nodal disease, extranodal extension, in transit metastasis, T3 or greater tumor, and as you can see, PNI or lymphovascular invasion. Now, this is also going to be applied in the experimental arm. So if a patient responds to neoadjuvant treatment, but still has a positive node, then they would get adjuvant radiation. Or if they have residual perineural invasion or a positive margin, for example, they would receive adjuvant radiation. But we expect that based on the phase 2 data that many patients will fall out of an indication for adjuvant radiation in the experimental arm. And that's why we've advocated for a curtailed adjuvant immunotherapy portion for these patients who have a partial response. Next slide. And so the adjuvant immunotherapy is going to be given specifically for patients who do not have a pathologic complete response. And this will be just 4 doses. And in this case, it'll be given every 6 weeks. And if patients are tolerating it and there's no evidence of disease, then they will complete that. And so we think this offers a real benefit to the patients we think are at higher risk, but without adding undue risk of toxicity or excessive treatment. Kind of finding the sweet spot where we're directing the treatment towards the patients we think are going to benefit most. Next slide. These are the statistics. I won't dig into those, but again, the sample size is 420. Next slide. This is the timeline that, I guess the justification of the font is a little off. Next slide. I think the key is here is that we have, just as this month, CTEP approval. And as I mentioned before, it's at the CIRB now. And next slide. Our plan is to activate in October. Next slide. Okay, so I think that's kind of the overview of the trial. I'm happy to entertain questions. We're really excited about, you know, the international partnership here. In this case, it's really focused between NRG and TROG. But, you know, the hope is that this could be a model for future broader international collaboration.
Okay, thanks very much. That's really impressive, and it's really impressive to see somebody who knows this trial so well that they can do that while driving. So thank you. I think there's tremendous anticipation for this and excitement, and as you mentioned, we all hope this is a model for future international collaboration. And behind the scenes, Dr. Suyam was working tirelessly on this, and I invited her to maybe just share some thoughts of lessons that we could learn just for a few minutes.
Yeah, is Sue on?
Hi there. Hi, Neil. Wonderful.
Oh, hey, Sue.
Wonderful presentation. I like the updates. It's getting just great. I hope everyone can see what a thoughtful trial this is, and I want to reinforce Dr. Korn's point that this is the reason for that is that this has been an incredible partnership, not only with our sponsor who has been really open to the scientific and intellectual questions as opposed to other interests, but also the incredible expertise of the team. So we brought Australian partners on very early who are on the study team. And I will say that the discussions within NRG and with our collaborators across the board, as well as with CTEP, have really contributed to this trial. I just want to say two things that have come up about this trial. Number one, both Dr. Gross and I remain super committed to the concept of randomization here. I realize many people are very interested in using immunotherapy in this disease because of the response rates, but that's not enough. This trial is actually looking at whether use of immunotherapy, which is expensive and does have toxicity, is going to make a difference in the disease status of these patients and their long-term outcomes. And that is a really important thing before we jump off the cliff and start giving immunotherapy to all these patients. It's the right thing to do, and NRG will do that. And very grateful to our sponsor for giving us that opportunity. Number two, so the equipoise is important. And number two is you can see the thoughtfulness of this trial, the components here with response adaptive surgery, with responsive RT, with management of immunosuppressed populations for the first time, and discussion of how to allocate patients according to their pathologic response. And then finally, novel quality of life instruments that have never been used in this disease that have been created according to clinical expertise at a deep level for this disease. There are so many components in this trial, and if your center wants to understand how to manage skin cancer going forward in the 21st century, you want to be on this trial, because this is setting so many things up for how this disease will be managed and defined in the future. And finally, just want to say that we are so grateful to the leadership of NRG, to our three group chairs who have supported developing this really complex concept and giving us the opportunity to work with Australian, Canadian, and Japanese colleagues to really make this a trial that will speak to the world. So I really am excited about this. Just crossing our fingers till we get that baby born. But please, please do support the trial if you have interest in skin cancer. We would love to have you.
Thank you all very much. We're going to move now to the last two speakers. Kate will give us some updates on the open protocols for international participation.
Is it possible that I could just make one comment about that last study? This is Mac Roach.
Please, Mac.
Yeah, I just, inspired by that last presentation from last season, I contacted some folks from the UK that are running this, that are using this drug in the setting of penile cancer. I'm assuming that they're still not eligible for the study, but this is for penile cancers with a non-mucosal component. So it's a skin cancer, typically involving the foreskin, but can involve in other locations. And so we're going to try to do the same thing, but in penile cancer. I think the endpoint is liable to be a little bit more, a little bit different, but I'm very excited about following up on all this exciting data. Just thought I'd make that point. Thank you.
Thank you.
On this next slide are the trials that are open to international sites, and also included in the meeting invitation was an additional international trials table, and it provides more information on each of these trials, and that was in your meeting invitation.
I'd also like to give an update on the ID.me process for international members and Canadian members, because we did receive more detailed information from NCI on this. So because international and Canadian members had given response that the process was pretty intrusive. NCI went back and worked on a new workflow that will be available by August 1st. This moves the identity verification process in the pathway to the site-level verification process, and that's for new users, new CTEP IAM users only. So new Canadian and international site staff will have their new CTEP IAM account requests verified by designated verifiers at their site, and the process for that is being ironed out currently. However, existing international staff with CTEP IAM accounts will be grandfathered in, so they won't need to be re-verified. We did want to make a note that all international staff still need to onboard with ID.me and set up the multi-factor authentication. So this is a required step, and it must be done by September 30th of this year, or you will not be able to access NCI systems. One point to make is that with the onboarding and the multi-factor authentication, you do not need to use, you won't need to give any additional information besides name, telephone, and email address, the same information that you would give to CTEP. This is the new workflow for existing users. So you, at any time after August 1st, when the workflow is in place, you can log in using your CTEP IAM username and password. You will automatically be approved to move on to the next step, which is to navigate to the ID.me information section. And then you can go forward with creating a new ID.me account and setting up the multi-factor authentication. As I said before, no documentation needs to be submitted to verify your identity. The important last step that we don't want people to forget is to share the ID.me information to link the credentials to your CTEP IAM account. There will be a slide on this in just a little bit. For new users, the proposed workflow will be that when they submit a CTEP IAM new account request, there will be someone with a role at each site that will verify the new user's identity. They will document this and check off that they approve each user, and then they can go forward with getting CTEP registration help desk to process the account request and set up their new ID.me account with MFA, and also share the information and link. For the MFA, this is just a screenshot that shows where to set it up with ID.me. After logging on, you'll be redirected, and there's instructions provided. You'll need to give name, telephone, email address, and this information will not be used for identity proofing purposes. For the next step, with the screenshot shown, you will set up your MFA option. There are multiple options, and these are available to all Canada and international-based users. The most frequent used is text message and push notifications. I use them myself. It's pretty easy to log on. Then the last step that's very important, after you've done both of those, you need to allow the sharing option, which is shown below on the slide. This will link your ID.me credentials with your CTEP IAM account. And then going forward, you will no longer use your CTEP IAM login. You'll use your ID.me login to get into all NCI systems. Wanted to point out some helpful resources and tips. NCI is having live webinars that use some of these slides and even more. I attended one earlier this week, and it was very informative, so I suggest that anyone who's not already using the ID.me system to please look into the two that are upcoming. These are geared specifically towards Canadian and international researchers and staff. So there is one in August and one in September. And the times listed here are Eastern times in the US. So they do have one available overnight in the US, so hopefully those in other countries will be able to attend and not have to stay up too late or wake up too early. There is a link, yeah, the time difference really. There is a link as well on the slide that will take you right to how to register for it. It is free and open to everyone. And then there's also information through NCI about this process. They wanted to give some information on if you're having trouble, you can contact the CTEP help desk at their email address. And then NCI has a whole web page for the ID.me transfer process. Thank you.
Okay, thank you very much. A lot of work there. So again, in our last minute, I want to express gratitude to energy leadership. I don't think there are many subcommittees that get so much attention from chairs and vice chairs of this distinguished group. And I wanted to also thank Dr. Miller for his guidance on the membership committee and for all the help in keeping this coalition together. So thank you very much for participating today, and we're all available online for additional questions.
Thank you all for joining. This concludes our meeting.